Imagine a tiny bone in your wrist, no bigger than a sugar cube, suddenly losing its lifeline, its blood supply. What happens then isn't just a simple sprain or a minor ache. It's a journey into chronic pain, progressive stiffness, and actually a surprisingly complex medical condition we're diving deep into today.
Indeed.
We're talking about Kienbock disease, a condition that, at its core, involves the avascular necrosis, or you might hear osteonecrosis, of the lunate bone in the wrist.
Lunatomalacia is another term you might come across.
Right, lunatomalacia. It's a rare condition, often quite insidious, initially mimicking far less serious problems, which must make diagnosing it a significant challenge.
Exactly. And our exploration today isn't just a general overview. It's a deep dive, specifically tailored to the source materials you've provided, a stack of articles, research papers, excerpts from various medical resources like Stat Pearls, Ortho Bullets, the Hand Society, and others, all focusing on this specific condition.
Okay, so our mission, leveraging these resources, is to extract the most important, insightful information. We want to understand precisely what Kienbock disease is, maybe unravel the mystery of why it happens, given there seems to be no single cause.
That's a key point. It's multifactorial.
Right. And identify who it typically affects, delve into how medical professionals diagnose and stage its progression using different imaging techniques.
Which is crucial for treatment.
Absolutely. And explore the range of treatment options available, from non-surgical approaches right through to quite complex procedures, and critically understand what the long-term outlook and potential future holds for someone living with this condition. It's really about turning dense medical information into clear, actionable understanding for you listening.
Think of it as your essential guide to becoming well-informed about Kienbock disease, extracting the core knowledge and key considerations directly from the expert literature we've looked at.
Okay, let's unpack this. Let's start with the anatomy and the star of our deep dive. That tiny bone, the lunate.
The lunate, yes.
So this whole condition revolves around the lunate bone. Where exactly is it located, and why is it such a crucial player in the wrist's mechanics?
Well, the lunate holds a really central and critical position in the wrist structure. It sits squarely in the middle of the proximal carpal row. That's the first line of 8 small carpal bones in your wrist, the ones closest to your forearm.
Okay.
Its neighbors are the scaphoid on the thumb side and the trichotrum on the pinky side, with the pisiform sort of sitting on the trichotrum. More importantly, it articulates or connects directly with the 2 long bones of your forearm, the radius and the ulna.
How does it connect to both?
It connects specifically through the radial side and then via the triangular fibrocartilage complex, or TFCC, on the ulnar side.
So it's literally right there, bridging the forearm and the hand. What does that central position mean for its function?
It means it's absolutely fundamental to wrist movement and load bearing. The lunate acts as a key intermediary, facilitating the complex range of motion we have in our wrists: flexion, bending down, extension, bending back, and to some extent, that side-to-side deviation as well.
And the load-bearing aspect.
Yes, perhaps its most significant role, and one that's highly relevant to Kienbock disease, is its function in absorbing and transmitting the forces that travel through your hand and wrist, particularly during activities like gripping, lifting, or bearing weight on your hands.
Right. That makes sense.
Our sources actually provide some fascinating statistics on this load transmission. Approximately 35% of the axial load that goes through your wrist during these activities is transmitted directly through the articulation between the radius and the radial lunate joint.
25%. Wow.
And another 10% goes through the TFCC to the ulna. So yeah, a significant portion of force, about a third, is concentrated right on this one small bone.
35% of the source going through your wrist on a bone no bigger than a sugar cube. That sounds like an awful lot of stress for such a small structure.
It is.
It's no wonder that if something goes wrong here, the consequences can be significant.
Precisely. And the history of understanding problems with this bone goes back further than you might think. While there were earlier observations, figures like Peste back in the 19th century, the specific condition we call Kienbock disease was formally described by Robert Kienböck, an Austrian radiologist, in 1910.
1910. So we've been piecing together the puzzle of this lunate failure for well over a century.
We have indeed.
Who is typically affected by this condition? Is there a pattern in the patients diagnosed?
The data from the sources does show a typical demographic profile, although it's not exclusive, of course. It predominantly affects males, generally within a relatively specific age range, most commonly between 20 and 40 years old.
Younger men, mostly.
Yes. And while it's considered a rare condition overall, within the category of avascular necrosis affecting the carpal bones, it's the second most common type, after AVN of the scaphoid bone.
Okay, second only to the scaphoid.
Correct. Interestingly, the sources also note that it's quite rare to see Kienbock's disease affecting both wrists at the same time. It's usually unilateral, just one side.
So, younger to middle-aged men are the most common demographic, though certainly not the only ones affected. Now, the big question, and one the sources emphasize, is still not fully answered. Why does this happen? Given the central role of blood supply loss, you'd think there'd be a clear cause.
You would, wouldn't you?
But the sources are clear. There isn't one single consensus reason. It's described as multifactorial.
That's right. The mystery of Kienbock's is that it seems to arise from a confluence of factors rather than a single event or deficiency. The sources detail several key proposed mechanisms that likely interact to lead to the disease.
Okay, what are the main contenders?
One of the most compelling and frequently cited is biomechanical imbalance. Specifically, variations in the lengths and angles of the bones in the forearm and wrist. The most prominent example is ulnar negative variance, often called ulna minusus.
Okay, let's break that down. Ulnar negative variance, what does that actually look like in the wrist?
Simply put, it means the ulna bone, that's the forearm bone on the pinky side, is congenitally shorter relative to the radius bone, the one on the thumb side.
Okay, shorter ulna.
Because the radius is relatively longer, the load that should ideally be shared between the radius and the ulna gets disproportionately shifted towards the radial side of the wrist.
Ah, so the lunate, sitting mostly under the radius, ends up taking on an even greater share of that load than it normally would, more than that 35%.
Exactly. That 35% load transmission through the radial lunate joint gets magnified. The sources cite studies showing a remarkably high correlation between Kienbock's disease and ulnar negative variance, up to 78% in some patient populations.
78%, that's huge.
It is. It suggests that even a small anatomical difference in bone length can have a profound biomechanical consequence over time. Another related factor mentioned is a decreased radial inclination angle, which is the angle formed by the end of the radius bone. A lower angle here also seems to direct more force onto the lunate.
It's fascinating how such subtle variations can predispose someone to this serious condition. What else contributes?
Well, repetitive microtrauma and compression loading are also strongly implicated. While a single traumatic event can sometimes play a role, the sources emphasize that cumulative stress from repeated wrist movements, perhaps hyperextension, flexion, or significant axial loading.
Like from certain jobs or sports?
Precisely, like from certain sports, manual trades, or even just repetitive heavy gripping. This can cause microdamage to the lunate. Now, if this microdamage outpaces the bone's ability to repair itself, it can compromise the local blood supply.
So constant low-level stress, not necessarily a single big injury, could be part of the problem. You mentioned blood supply earlier. That seems absolutely fundamental to avascular necrosis.
It absolutely is.
Mm-hmm.
And the specific anatomy of the lunate's blood supply makes it particularly vulnerable. It receives blood from a network of small arteries that penetrate the bone from the dorsal, the back, and volar, the palm, sides of the wrist. These form anastomoses connections outside the bone.
Okay.
But the crucial point highlighted in the sources is that the lunate has relatively sparse intraosseous collaterals, meaning there aren't many backup blood vessels running within the bone itself to provide alternative routes for blood flow if one of the main penetrating arteries gets compromised.
So if a main supply line is blocked or damaged, there aren't many internal detours to keep the bone alive. That sounds like a significant point of vulnerability.
It really is.
Yeah.
And the sources specifically note that a lower number of these penetrating arteries, especially the volar branches coming from the palmar radiocarpal arch, is associated with an increased risk of developing Kienbock's.
Fewer entry points, more risk.
Exactly. Different patterns of arterial supply have even been identified, described as YX or I patterns. The I pattern, where there are fewer connections and less redundancy, is found in a significant proportion of patients, around 31%, and is postulated to be the most precarious in terms of blood supply.
So the I pattern might put those individuals at higher risk?
Potentially, yes. The sources also mentioned the possibility of disruption to venous outflow, getting blood out of the bone. If that's impaired, it could lead to increased pressure within the bone, further compromising blood flow.
Ah, so it's not just getting blood in, but also getting it out.
Precisely. Venous outflow is part of the puzzle.
So the lunate's blood supply is naturally a bit precarious, and if you have fewer main entry points or struggle to get blood out, it's a setup for potential failure. What about the bone's own structure or shape? Does that play a role?
Yes, lunate morphology is another piece of the puzzle. The size and shape of the lunate itself matter. Logically, a smaller lunate will experience higher stress per unit area under the same load. More significantly, perhaps, the shape plays a role. Lunates are often described as either more triangular, type 1, which lacks a medial articular facet, or more square rectangular, type 3, which has that facet. The type I lunate is considered a risk factor because it seems to have a weaker internal trabecular pattern, making it potentially less resilient to stress.
So a combination of biomechanical stress from potentially misaligned forearm bones, repetitive microtrauma, a naturally fragile blood supply pattern, and maybe even a smaller or weaker shaped lunate bone. It really does sound like multiple risk factors converging to overwhelm this small bone.
It's precisely that sort of perfect storm scenario that the sources point towards. And while a history of a single significant trauma is sometimes reported and can contribute, the sources emphasize that in a surprising number of cases, there's no clear traumatic event in the patient's history. The onset is often more gradual, more insidious.
And are there any other medical conditions that seem to increase the risk? Any systemic links?
Yes. The sources list several systemic conditions that are associated with Kienbock disease. These include conditions that might affect blood clotting or circulation, like sickle cell anemia, or inflammatory conditions like gout and lupus.
Okay.
Cerebral palsy is also mentioned, though the mechanism there might be related more to abnormal muscle forces affecting wrist mechanics. Osteoporosis, a condition causing weakened bones, particularly in older women, is also noted as a potential factor, though Kienbock is generally less common in that demographic compared to younger males.
So these conditions might predispose someone by affecting the health of blood vessels or the bone tissue itself.
That seems to be the thinking, yes. They add another layer of potential vulnerability.
It's quite remarkable how seemingly unrelated systemic health issues can connect back to this problem in a tiny wrist bone. You touched on it briefly, but I've often heard Kienbock mentioned in the context of occupational hazards, like using vibrating tools. Does the research in the sources strongly support that link?
That's a common association, certainly, and historically, occupational exposure, particularly to hand-arm vibration, was strongly suspected. However, the sources specifically highlight a systematic review which found, perhaps surprisingly, only weak evidence to definitively link Kienbock disease directly to occupational hand-arm vibration exposure.
Oh, really? Weak evidence.
Yes. So, while the idea of repetitive stress contributing is still very valid, the specific link to occupational vibration tools appears less strongly supported by current reviews in the sources than perhaps previously thought. This is a key point to note, as it does challenge a common assumption.
Okay, so to sum up this complex etiology, it's rarely one single thing. It's more likely a combination of subtle individual anatomical variations, the mechanical demands placed on the wrist, a predisposed vascular architecture of the lunate, and potentially contributing systemic health issues. It's a fascinating interplay of factors.
It truly is a multifactorial puzzle, and getting a handle on these potential contributors is crucial for diagnosis and deciding on treatment, even though the exact cause in any individual case can still be difficult to pinpoint definitively.
And that difficulty brings us neatly to our next segment, experiencing this disease and the process of figuring out what's actually going on.
Diagnosis and evaluation, yes.
So someone is starting to feel pain in their wrist. How does Kienbock typically manifest from the patient's perspective? What are the common symptoms?
Well, the sources describe a typical presentation that unfortunately often starts quite subtly. The most common initial symptom is pain, usually felt on the dorsal or back side of the wrist, right over where the lunate bone sits.
Okay, dorsal wrist pain.
Initially, this pain might be mild, intermittent, perhaps just feeling like a nagging ache after certain activities. It's very often dismissed, as just a sprain or a minor strain, which contributes to that delay in diagnosis we mentioned earlier.
So it's not usually a sudden, acute pain at the very beginning, like a fracture might be.
Not typically, no. It's more often a gradual onset.
Oh.
The pain characteristically worsens with activities that put stress through the wrist, especially those involving wrist extension, bending it backwards, or significant axial loading.
Like push-ups or lifting.
Exactly. Things like push-ups, lifting heavy objects, or any task requiring strong gripping or leaning on the wrist. As the disease progresses and the bone degenerates, this activity-related discomfort can become more constant and debilitating, significantly impacting daily function.
What else might someone experience?
Beyond pain, other symptoms tend to emerge. On physical examination, a doctor might find localized swelling over the lunate area. There's almost always significant tenderness when pressing directly over the lunate bone on the back of the wrist. Synovitis, which is inflammation of the joint lining, can also be present, contributing to the swelling and a feeling of stiffness.
And what about the wrist movement? Does that get affected?
Yes, range of motion becomes increasingly limited as the disease advances. You'll typically see a measurable decrease in both wrist flexion, bending down, and extension, bending back. Grip strength also diminishes, which makes sense given the lunate's role in load transmission during gripping.
Okay, so pain, swelling, tenderness, stiffness, reduced grip.
And in later stages, as the lunate bone begins to collapse and fragment and the overall carpal alignment changes, patients might start to notice mechanical symptoms. Things like clicking, popping, or perhaps clunking sensations within the wrist during movement.
Ah, that sounds like things are really starting to degenerate.
It's often a sign of instability and advancing joint degeneration, yes.
So it starts deceptively simply, but can progress to significant pain, stiffness, weakness, and even those mechanical noises. You mentioned earlier, though, that symptom severity doesn't always line up perfectly with the stage seen on imaging.
That's a crucial point emphasized in the sources, and one that makes managing expectations, well, quite challenging. Yes, you can have someone experiencing severe, debilitating pain early on, even when imaging only shows stage 1 or perhaps stage 2 changes.
Really?
Yes. Conversely, some individuals with radiographic evidence of more advanced stages might report surprisingly manageable pain levels for a period of time. This variability highlights the complex nature of pain perception and the disease's sometimes unpredictable clinical presentation.
Given the subtle onset and that potential symptom stage mismatch, how do doctors go about diagnosing Kienbock disease? What's the investigative process?
Diagnosis is fundamentally a clinical and imaging diagnosis. It starts with a detailed patient history, understanding when the symptoms began, what makes them worse, any history of trauma or repetitive activities, and reviewing any associated systemic conditions we talked about.
The detective work.
Exactly. Followed by a thorough physical examination to assess that tenderness, swelling, range of motion, and grip strength. But imaging is absolutely essential to confirm the diagnosis and, importantly, to stage the disease.
Right, staging is key. How does the imaging usually proceed?
The imaging process often follows a progression. Standard radiography, X-rays, are usually the first step. However, and this is a critical limitation, X-rays are often completely normal in the very early stages, stage I.
So a clear X-ray doesn't mean you're in the clear.
Not at all, especially early on. The classic radiographic signs only appear later. What doctors look for in X-rays as the disease progresses are things like increased density of the lunate bone, sclerosis, which makes it appear whiter on the image due to hardening and attempted repair.
Okay.
Also, cystic changes, small fluid-filled areas within the bone, obvious collapse or fragmentation of the lunate, changes in the alignment of the other carpal bones, what we call carpal collapse, and signs of secondary arthritis or arthrosis in the joints around the lunate.
Do they need special X-ray views?
Yes, X-rays are also needed in specific views, like a zero-rotation PA view, to accurately measure that ulnar variance we discussed earlier, as well as the radial inclination. They can also pick up coronal fractures within the lunate in later stages.
So a normal X-ray definitely doesn't rule it out, especially early on. What's the next step in imaging then? If the X-ray is normal but Kienbock is still suspected?
Because X-rays are often normal initially, MRI, magnetic resonance imaging, is considered the most sensitive diagnostic tool, particularly for detecting early-stage disease that isn't visible on X-rays, what we call radiographically occult cases. An MRI can directly visualize the changes in the bone marrow associated with loss of blood supply.
What specifically does an MRI show in early Kienbock? What's the giveaway?
The hallmark finding on MRI, especially on T1-weighted images, is a diffuse decrease in the signal intensity of the lunate bone marrow. This darkening of the bone marrow is indicative of disrupted blood flow and fat necrosis within the bone.
Right, so the MRI sees the blood supply problem directly.
Essentially, yes. As the disease progresses, the signal characteristics on other types of MRI sequences, like T2-weighted or S-STORA images, can change, reflecting things like edema, swelling, fragmentation, or those cystic changes. MRI is also invaluable for assessing the health of the surrounding cartilage and ligaments, helping to identify complications like scapholunate ligament injury or maybe ulnar impassion syndrome, which can sometimes mimic or coexist with Kienbock.
So MRI is key for catching it early by assessing blood supply and soft tissues, while X-rays are more useful for visualizing structural changes and overall alignment in later stages. What about CT scans? Where do they fit in?
CT computed tomography is particularly useful once structural damage is suspected or confirmed on X-ray, especially when surgical planning is being considered. CT provides exquisite bony detail.
Better than X-ray for bone detail.
Oh yes, it's more sensitive than X-ray for detecting subtle subchondral fractures. That's fractures just below the cartilage surface, any coronal lunate fractures, the precise degree of fragmentation of the lunate, and the extent of carpal instability patterns. The sources mention that patients are actually frequently restaged after getting a CT scan because it often reveals more extensive bony damage or instability than was apparent on the initial X-rays.
Okay, so X-ray for general overview and alignment, MRI for early blood supply issues and soft tissue, and CT for detailed bone structure and fragmentation, especially important for surgery planning. Was there an older imaging technique used? Something else mentioned.
Yes, nuclear scintigraphy, or a bone scan, was used historically as an adjunct tool, particularly for suspected early cases when MRI wasn't perhaps as widely available or sophisticated as it is today. It could show increased uptake in areas of bone injury or decreased uptake in areas of significant necrosis,
But less common now.
much less common now. Given the superior sensitivity and the detailed anatomical information provided by MRI, bone scans have largely fallen out of favor for diagnosing Kienbock disease specifically.
It sounds like piecing together the diagnosis, especially in those crucial early stages, really requires a high index of suspicion and using the right imaging tools at the right time. It's easy to see how delays could happen.
They are, unfortunately, very common. As the sources note, the challenge of early diagnosis is significant precisely because those initial symptoms are vague and X-rays are often normal, necessitating the use of MRI. Patients frequently experience diagnostic delays, sometimes for months or even years, which sadly allows the disease to progress further before any intervention.
Once the diagnosis is made, how do doctors classify how severe the disease is? This is where staging comes in, right? You mentioned that's crucial.
Correct. Staging is absolutely fundamental. It provides a framework for understanding the disease's progression, and most importantly, it guides treatment decisions. The most widely used system is morphologic staging, based on the Lichtman classification.
Richtman classification. Okay.
This classification relies primarily on radiographic findings, mainly X-rays, often refined by CT, and it's known for its relatively low inter-observer variability, meaning different clinicians tend to agree on the stage when looking at the images.
What are the stages?
The Lichtman classification breaks down the progression of the lunate's deterioration and its effect on the surrounding wrist structure. Stage 1. This is the earliest stage. Crucially, standard X-rays appear normal. The disease is only detectable at this point on MRI, which shows those characteristic signal changes indicating compromised blood supply, ischemia, and edema.
So MRI positive, X-ray negative.
Exactly. Stage 2. Now, changes become visible on X-ray. The lunate shows increased density, or sclerosis. It looks wider and more opaque than normal bone. The overall shape and size of the lunate are still preserved at this stage, but subtle fraction lines might start to appear within the bone.
Okay, density changes on X-ray.
Yes. Stage 3. This is defined by collapse of the lunate's articular surface, that smooth surface that connects with other bones. It's subdivided further. Stage 3. The lunate has collapsed, but the overall alignment and height of the carpal bones in the wrist are still preserved. No major structural shift yet. Stage 4Z. The lunate collapse is more significant, and it starts leading to changes in carpal alignment. The scaphoid bone typically starts to flex forward, and there is a measurable loss of overall carpal height. This often results in a specific pattern of instability called a DISI deformity, dorsal interpolated segmental instability. Stage I. This is similar to IB with collapse and loss of carpal height, but specifically includes an associated coronal fracture of the lunate, a fractal line visible on imaging running vertically through the bone.
So stage 3 is all about collapse and its effect on alignment.
Precisely. Then finally, stage 4. This is the end stage. It includes the significant collapse and carpal height loss seen in stage IB, plus the development of secondary degenerative arthrosis, basically arthritis in the radiocarpal joint, between the radius and the proximal carpal row, and or the midcarpal joint, between the two rows of carpal bones.
So the Lichtman classification is essentially mapping the physical destruction of the bone and the cascade of effects on the rest of the wrist structure. Is there another way to stage the disease? You mentioned imaging blood flow earlier.
Yes, there's also functional staging. This is typically assessed using contrast-enhanced MRI. While morphologic staging tells you about the structural damage, functional staging tells you about the actual blood flow and the extent of viable living bone tissue within the lunate.
And that's important for treatment planning.
Very much so. It's particularly valuable for guiding treatment decisions regarding revascularization procedures, which really only have a good chance of working if there's enough viable bone remaining. Typically considered useful in stages 1, 2, and perhaps early stage AA.
How does functional staging work with the contrast dye?
Functional staging, based on how the lunate enhances after injecting contrast dye, looks something like this. Stage 1. After the contrast injection, the lunate shows intense, homogeneous enhancement. This indicates good blood flow and viable bone, corresponding usually to morphologic stage I, where there's ischemia and edema, but not yet established necrosis. Stage 2. The enhancement is patchy and inhomogeneous. This suggests partial necrosis has occurred, but there are still areas of viable bone, often in the distal part of the lunate. This typically corresponds to morphologic stage 2, stage 3. There's a complete absence of contrast enhancement within the lunate. This indicates full-blown, complete avascular necrosis with no significant blood flow remaining, usually seen in morphologic stages the 3A and beyond.
So doctors use both morphologic staging to understand the structural damage and functional staging to understand the biological viability of the bone itself? That combined picture must be absolutely essential for deciding on the best course of action for each patient.
It's precisely that comprehensive assessment that allows for tailoring treatment. Kienbock is definitely not a one-size-fits-all condition when it comes to management.
Which leads us perfectly into the final piece of this puzzle, navigating the treatment options and what the road ahead looks like for someone diagnosed with Kienbock disease.
Yes, the management strategies.
So we've mapped the disease's progression through staging. What are the main goals when doctors and patients discuss treatment for Kienbock? What are they trying to achieve?
The fundamental goals of treatment, as outlined pretty consistently in the sources, are threefold: alleviating pain, preserving as much wrist motion as possible, and maintaining or restoring grip strength.
Pain, motion, strength. Makes sense.
However, the strategy for achieving these goals is highly dependent on several factors. The specific stage of the disease, of course, based on Lichtman and functional staging, the patient's symptoms and their functional demands, what they need their wrist to do, and crucially, the presence of those contributing biomechanical factors like ulnar negative variants.
So treatment is very much tailored to the individual and their specific wrist anatomy and disease state.
Absolutely. Highly personalized.
Let's start with the less invasive options. What happens in the earlier stages, or perhaps for patients with milder symptoms?
For early stage disease, typically stage 1 and potentially some cases of stage 2 where there's incomplete necrosis, non-operative approaches are usually considered initially. The most common method is immobilization of the wrist, usually with a cast or a rigid splint.
Immobilization. How long might someone need to be immobilized for? Does it vary?
That duration varies quite significantly, as the sources highlight. While some studies report average immobilization periods around, say, 8.6 months, historical accounts in the literature mention extremes of up to 20 years of casting, though that would be highly unusual in modern practice.
20 years? Goodness.
Yes. Immobilization is often the preferred initial treatment for specific demographics, such as adolescents, where bone healing potential might be different, and perhaps older adults over the age of 70, where surgical risks might be higher.
Does immobilization often lead to healing in adults? Does it fix the problem?
Unfortunately, the sources are quite clear on this. In adults, spontaneous revascularization and healing of the lunate with non-operative treatment alone is rare. The disease is likely to progress to later stages despite prolonged casting in most adult cases.
So it doesn't really stop it.
Not usually in adults, no. A majority of adult patients initially treated non-operatively will eventually require surgical intervention if they remain symptomatic or the disease clearly advances on imaging. So, while immobilization might provide temporary pain relief by resting the wrist, it typically doesn't alter the underlying progressive course of the disease in adults.
Okay, so it's more about symptom control, maybe?
In many cases, yes. Other non-operative measures include pain management with simple analgesics like paracetamol or NSAIDs to reduce pain and swelling, and sometimes just observation combined with activity modification, advising patients to avoid activities that aggravate their pain. Again, while these can help manage symptoms, the sources indicate that most adult patients treated solely with observation or activity modification will eventually need more definitive management due to symptom progression or functional decline.
Okay, so non-operative is mainly for symptom management, specific patient groups, or maybe as a holding measure. More often than not, it seems surgery becomes necessary. What are the main categories of surgical intervention then?
Operative treatment strategies broadly fall into two main categories, or sometimes a combination of both. One aims to restore blood supply to the lunate. These are the revascularization procedures. The other aims to reduce the mechanical load or stress on the lunate and further stabilize the wrist. These are often called joint leveling or salvage procedures.
Okay, let's talk about relieving the pressure first, the joint leveling ones.
Right, these are the joint leveling procedures designed to offload the lunate. They're particularly relevant when that contributing factor of ulnar negative variance is present, but variations are also used for neutral or even positive variance situations.
How does he that?
The most common procedure for significant ulnar minus is a radial shortening osteotomy. This involves surgically removing a small segment of the radius bone to make it shorter, thus equalizing the lengths of the radius and ulna at the wrist joint and shifting load away from the lunate onto the ulnar side.
Does she shorten the longer bone?
Exactly. Alternatively, though less common, an ulnar lengthening osteotomy can be performed to achieve the same relative length. For wrists with neutral or positive ulnar variance, where the ulna is already the same length or longer, a radial wedge osteotomy can be used. This involves cutting a wedge shape out of the radius to alter the angle of the radial joint surface, again aiming to shift load off the lunate.
So you're literally changing the bone's alignment to create a better biomechanical environment for the struggling lunate. Do these procedures make a significant difference in how much stress the lunate actually bears?
They can have a really dramatic effect. The sources cite some compelling data. A radial shortening or ulnar lengthening of just 4 millimeters can result in a substantial 45% decrease in the contact stress on the radial lunate joint.
45%, that's huge.
It is. This reduction in load provides a much better environment for potential healing, or at least slowing down progression, particularly useful in the earlier stages, typically stages 2 and higher IA.
That's a massive reduction from a relatively small adjustment. Okay, what about the other approach, trying to bring blood flow back to the lunate, the revascularization you mentioned?
Yes, these are the revascularization procedures. They are most appropriate in earlier stages, stages 5 and potentially early IDREA, when there is still a significant amount of viable bone remaining, which, as we said, can be assessed with that functional contrast MRI. The primary technique here is using vascularized bone grafts, VBG.
Vascularized bone graft, what does that actually involve? Sounds complex.
It is a complex microsurgical technique. It involves taking a piece of bone from another location in the body. Common donor sites include the distal radius itself, near the wrist, the iliac crest, which is part of the hip bone, or even using small bone pieces supplied by branches of the dorsal metacarpal arteries in the hand.
Like the 4+5.
Exactly. The 4+5 extensor compartment artery pedicle is mentioned as being favored sometimes for its good mobility. Crucially, this bone piece is transferred with its attached blood vessels still intact and functioning. These tiny vessels are then surgically connected, anastomosed, to blood vessels near the lunate, effectively aiming to give the lunate a new, living blood supply and also some structural support.
Bringing in reinforcements with their own supply lines?
That's a good way to think of it. Another revascularization technique mentioned, often used in earlier stages, I5-CDSE, is distal radius core decompression. This involves drilling small holes into the distal radius near the lunate attachment.
Why drill holes?
Well, the thinking is it might potentially reduce the pressure within the bone, the intraosseous pressure, and perhaps stimulate a local healing response and encourage the ingrowth of new blood vessels from the radius towards the lunate. Sometimes, temporary pinning across the wrist or external fixation is used alongside revascularization to temporarily hold the wrist bones in a position that minimizes stress on the lunate, allowing the graft or decompression effect to establish.
How successful are these?
VBGs are certainly promising, especially in younger patients with early-stage disease. However, the sources do note that long-term outcomes can be variable, and success really depends on the graft properly integrating and that new blood supply being sufficient and sustained.
Okay, so leveling the bones to reduce stress or bringing in new blood supply with bone grafts. What happens when the lunate is already significantly collapsed or the wrist has become unstable or arthritic, those later stages, IIB and 4?
In these more advanced stages, the focus often shifts away from trying to save the lunate itself towards salvage procedures. These aim to eliminate pain and stabilize the wrist, acknowledging that restoring full, normal motion may not be achievable. One category here is partial wrist fusions, arthritis.
Partial fusion, what does that mean exactly? Fusing only some bones.
Precisely. It means surgically fusing specific carpal bones together while leaving others free to move. The goal is usually to create stability, offload the damaged lunate area, or correct instability patterns like that dizzy deformity we mentioned, while hopefully preserving movement in the unfused portions of the wrist.
Which bones might they fuse?
Common partial fusions include STT fusion, which fuses the scaphoid, trapezium, and trapezoid bones together, or perhaps scaphocapitate fusion or capnohamate fusion. These are typically considered in stages 2, LAIA, and IIB.
What's the outcome of a partial fusion?
Well, a partial fusion can certainly reduce pain and provide stability, but it necessarily limits the overall range of motion compared to a healthy wrist because the fused bones no longer move independently. The choice of which bones to fuse depends very much on the exact pattern of collapse and instability present. The sources do mention differing opinions and evidence regarding which specific partial fusion is optimal for, say, stage IB, with some studies suggesting STT fusion might be preferred over other options like proximal row carpectomy in certain cases.
Okay, so partial fusion limits motion but helps pain and stability. What if the lunate is severely fragmented, collapsed, or there's already significant arthritis involving that whole first row of carpal bones?
That's where proximal row carpectomy, PRC, becomes a very viable option. This involves surgically removing the entire proximal row of carpal bones, the scaphoid, the lunate, and the trichotrum.
Removing all three.
Yes. This procedure is typically indicated for stages I, B, and 4, especially when the lunate is really beyond repair or the joints involving that proximal row are severely affected by arthritis.
Removing 3 bones from the wrist sounds quite drastic. What's the outcome like after a PRC?
While it sounds significant, PRC is actually a well-established procedure that can be very effective at relieving pain. It sacrifices that first row, but it preserves a surprising amount of wrist motion, usually around 50–60% of the normal range, by allowing the distal carpal row, the second row of bones, to articulate directly with the end of the radius bone.
So you still get decent movement.
You get functional movement, yes, and often good grip strength returns too. This makes it a favorite option for individuals who need reasonable pain relief and still require a degree of wrist flexibility, perhaps for certain professions or activities like playing musical instruments.
And if the arthritis is even more extensive, involving the radius itself or the entire wrist joint in stage 4.
When there's diffuse severe arthritis throughout the radiocarpal and midcarpal joints, often resulting from the end-stage collapse of Kienbock disease, then a total wrist fusion, arthrodesis, might be necessary. This is considered a definitive salvage procedure.
Total fusion, what does that involve?
Total wrist fusion involves surgically joining all the carpal bones together and then fusing this block of bones to the end of the radius bone in the forearm.
So everything is locked solid.
Essentially, yes. This procedure is extremely effective at eliminating pain because all the painful arthritic joints are immobilized. However, the trade-off is significant. You lose all motion at the wrist joint itself. No flexion, extension, or side-to-side deviation is possible. The hand is essentially fixed in a functional position relative to the forearm.
Right, so you trade all wrist movement for complete pain relief and maximum stability. Who is that typically recommended for?
Total wrist fusion is often recommended for individuals in stage 3 who require maximal strength and stability over flexibility, perhaps those performing heavy manual labor. It's important to note, though, that while you lose wrist motion, you retain full forearm rotation, turning your palm up and down, pronation and supination, which is crucial for many daily tasks.
What about just taking the lunate out? Is that ever done?
A more traditional and perhaps less commonly performed procedure now for advanced stages is simple lunate excision, just removing the lunate bone. However, this method on its own is associated with a high risk of subsequent carpal collapse and instability because of the void it leaves behind.
Right, things could just fall into the gap.
Exactly. So sometimes it's combined with interposition techniques. For example, using a harvested tendon, like the palmaris longus tendon from the forearm, fashioned into a ball to try and fill the space and maintain some carpal height and stability. That's known as tendon ball arthroplasty. It aims to mitigate some of the complications of just removing the bone.
Are there options for replacing the joint, like a prosthetic wrist?
Yes. Total wrist arthroplasty using an artificial joint replacement is also an option for stage 4 disease, similar in concept to hip or knee replacements. It aims to preserve more motion than a total fusion while still relieving pain.
But how reliable are they?
Well, the sources indicate that the long-term results and durability of total wrist arthroplasty are not as well established or predictable compared to total wrist fusion, particularly if the wrist is subjected to heavy loads. It's typically considered more for patients with lower functional demands or perhaps those who absolutely cannot tolerate the stiffness of a fusion, maybe due to bilateral issues.
Any other techniques worth mentioning?
The sources also briefly mention a couple of other techniques used in specific circumstances. Temporary scaphotrapeziotrapezoidal (STT) pinning can sometimes be used in adolescents with progressive pain to stabilize the scaphoid and unload the lunate while they're still growing. And a capitate shortening osteotomy, sometimes combined with a capitohamate fusion known as the Almquist procedure, is another approach designed to decompress the lunate, particularly in cases with neutral or positive ulnar variants.
Does shortening the capitate help the lunate?
It can. The sources give interesting data here too. Capitate shortening combined with capitohamate fusion can decrease radiolunate stress significantly by about 66%. However, it does transfer load elsewhere, increasing the stress on the radioscaphoid joint by around 26%, which could potentially increase the risk of future osteoarthritis developing there. So there are always trade-offs.
It's clear there are so many surgical paths, each with its own specific goals, indications based on stage and anatomy, and very distinct trade-offs in terms of pain relief versus motion versus stability. Choosing the right approach must be a really complex decision for both the patient and the surgical team.
It absolutely is. It requires very careful consideration of the disease state, the patient's individual functional needs and expectations, and a thorough discussion of the potential risks, benefits, and long-term consequences of each procedure.
After any of these treatments, whether it's non-operative immobilization or one of the surgical procedures, what does the recovery process typically involve? It can't be quick.
No, recovery is a critical and often lengthy phase that definitely demands patience and dedicated rehabilitation. Following a period of immobilization in a cast or splint, which, as we said, can range from several weeks to several months, depending on the procedure or the non-operative plan, patients then transition into rehabilitation.
And that involves therapy.
Yes, the core of recovery involves working closely with a specialized physical therapist or occupational therapist, often referred to as a hand therapist. Their role is absolutely crucial in guiding the patient through a structured program designed to regain function.
What does that structured rehab program typically look like? What are the stages?
It's typically staged, yes.
Yeah.
The initial focus is usually on managing any post-treatment pain and swelling, and then restoring basic gentle range of motion to prevent stiffness setting in. As healing progresses, the program advances to include strengthening exercises to rebuild muscle power in the forearm and hand, including grip strength, which is often significantly weakened by the disease and the period of inactivity. Finally, it moves towards improving fine motor control and dexterity through specific exercises, helping the patient regain the ability to perform more complex tasks needed for daily living or work. Hand therapists also provide essential guidance on activity modification and ergonomic strategies to help protect the wrist from excessive load or stress in the future, trying to prevent recurrence or further issues.
How important is that rehab?
It's vital for patients to understand that while rehabilitation is essential for maximizing their functional outcome, regaining as much strength and motion as possible within the limitations imposed by the disease or the chosen treatment, it doesn't cure the underlying disease process itself. The goal of rehab is really to help the patient adapt to their post-treatment wrist mechanics and maximize their ability to use their hand as effectively as possible.
Given the unpredictable nature of Kienbock that we've discussed and the range of interventions, what does the long-term prognosis look like for someone diagnosed with this condition? What does the future hold?
Well, the sources highlight a somewhat sobering reality. Kienbock disease, if left completely untreated, is considered invariably progressive. Without intervention, the loss of blood supply inevitably leads to bone death, fragmentation, collapse, and ultimately significant degenerative arthritis throughout the wrist. This progression can often lead to severe joint destruction and considerable loss of function within, say, 3 to 5 years of symptom onset in many cases.
That sounds quite serious if it's just left.
It is. It's ignored. However, and this is the unpredictable aspect we keep coming back to, the rate and extent of that progression can vary significantly between individuals. As the sources note, not every case marches predictably through all 4 stages from I to BIV.
So it's not always a straight line.
Not always. Some individuals, particularly those diagnosed in earlier stages or perhaps with less severe underlying risk factors, might experience much slower progression or have relatively mild symptoms for a longer period despite radiographic changes being visible. And in very rare instances, spontaneous improvement or even cessation of progression has been reported, though this is definitely uncommon, especially in adults. You can't rely on that happening.
So it's progressive generally, But the path isn't set in stone for everyone. What factors do influence the prognosis? What makes it more likely to be worse?
Several factors are associated with a less favorable prognosis and a higher likelihood of faster progression or worse outcomes. The functional stage we discussed is key. The greater the extent of viable bones seen on functional MRI, generally the better the potential for success with revascularization and perhaps a more favorable outlook overall.
Makes sense.
The degree of negative ulnar variance is also strongly correlated. The more ulna minus the patient has, the more severe the biomechanical stress, and the more likely the disease is to progress to advanced stages. Age at diagnosis is also a factor. Patients diagnosed at an older age are more likely to already have more advanced stage disease when they present and may experience more rapid progression subsequently.
And treatment, does that change the prognosis?
While treatment can significantly improve pain and function, the sources acknowledge that outcomes can still vary, often categorized in studies as excellent, good, fair, or poor. Treatment aims to manage symptoms, improve function, and potentially slow down the progression, even if the imaging findings in later stages still show considerable structural damage has occurred.
Are there long-term problems even after treatment?
Unfortunately, yes. Even after successful initial treatment, there are potential long-term complications to be aware of. These can include persistent or recurrent pain, stiffness, and residual limitations in motion or strength. Specific complications related to the altered wrist mechanics or the surgical interventions themselves can include things like lunate dissociation, that's instability developing between the scaphoid and the lunate's remaining portions or its neighbors.
Okay.
Also, secondary degenerative arthrosis or arthritis, developing over time in joints that now take on increased load because of the surgery, like the radioscaphoid joint after capitate shortening or certain partial fusions. And malignment of other carpal bones, like the triquetrum, can occur. That increased stress on the radial side of the wrist post-treatment is a persistent risk factor for developing future osteoarthritis.
And given the progressive nature and these potential complications, is it common for someone with Kienbock's to require more than one procedure over their lifetime?
Yes, that is a distinct possibility, particularly perhaps in younger patients or those with more aggressive disease patterns or who develop significant complications. The sources acknowledge that Kienbock disease can really be a lifelong condition requiring ongoing management, and some patients may unfortunately need multiple surgical procedures over time as the disease progresses or complications arise from previous interventions.
It truly sounds like a condition that requires a comprehensive, long-term approach, involving very careful decision-making every step of the way and relying heavily on an experienced healthcare team.
Absolutely. The sources really emphasize the value of an interprofessional team approach, involving hand surgeons, radiologists, and specialist hand therapists, all working together for optimal diagnosis, planning, and management throughout the patient's journey with this condition.
So we've taken a deep dive today into Kienbock's disease, exploring that delicate lunate bone, the complex interplay of factors from subtle anatomical variations to vascular patterns and repetitive stress that contribute to its mysterious failure.
We have. And we've seen how challenging diagnosis can be, often mimicking simpler issues initially, and how advanced imaging like MRI and CT is absolutely essential to truly see what's happening inside the bone and to stage the disease accurately using classifications like Lichtman.
And we've mapped out the wide spectrum of treatment options, haven't we? Ranging from fairly limited non-operative measures to quite complex surgical procedures aimed at leveling bones, revascularizing the lunate in early stages, or performing salvage procedures like partial or total fusions or proximal row carpectomy in later stages, each, as we've stressed, with its own benefits and inherent trade-offs.
And we've discussed the long view that while it's invariably progressive if left untreated, the disease course itself is unpredictable. And even with timely interventions and dedicated rehabilitation, it can lead to long-term complications and potentially require multiple procedures, making it a condition requiring ongoing care and adaptation from the patient. If you found this discussion helpful, perhaps consider sharing it with colleagues who might also benefit.
What stands out to you most about the complexity of Kienbock's disease? Especially considering those really difficult trade-offs patients and doctors must weigh, balancing pain relief against preserving precious wrist motion, or accepting the risks and limitations of potentially multiple interventions over a lifetime. It's a condition that really highlights the intricate mechanics of the human body and the profound challenges of intervening when a fundamental supply line to a critical structure fails, isn't it?
It really does. It underscores the importance of early diagnosis, tailored treatment, and realistic expectations. a fascinating and challenging condition.